Right, well, that's difficult to say because, first of all, if you can't get the correct diagnosis on your patients, and if you look at clinical trials, a lot of the ET trials have a lot of PV patients in them, you're not going to come up with the correct answers. So first, diagnosis has to be fixed, and people have to understand that. And it's sort of a emperor's new clothes, or everyone's afraid to say the emperor has no clothes. So first, fix the diagnosis. And the second thing is think about what you're trying to do with each group. So if you have people who are chimeras, such as the ET patients, they have less than 50% stem cells involved, you do the appropriate things, just like you would do in a low-grade lymphoma. It's sort of playing other people's money. If you don't have to treat somebody with anything, then that's great interest rates right there. And the patients you have to treat, what do you have to treat? Is it itching, which is a peripheral blood problem, or is it a spleen getting large, which is a tumor problem? So people have to figure that out. And the people that you worry about the most are the people with the high allele burdens, and that's the primary myelofibrosis patients. They're like CML patients. They present in full bloom. They virtually all have splenomegaly at that point. Their allele burdens are usually 80 or 90%. CML is exactly the same way. The difference is that all the JAK2 inhibitors we have do not really affect the stem cell that much. They affect committed progenitor cells, and they kill them, and they can do it effectively, but you get resistance to these drugs. And the good thing at the moment is we have a number of JAK2 inhibitors. If someone fails one, you can keep going. You can do that in CML, but more effectively. And the big thing is to learn how to hit the stem cell. And interferon hits the affected stem cell and drives it out from being dormant into cell cycle. And then the next question is, do you add something else to the interferon? Because you get about 20% complete molecular remissions, which is what you get in CML with the tyrosine kinase inhibitors. And why you don't get more, I do not know. I meant to say with interferon in CML you get 20%, not the tyrosine kinase inhibitors. So the question is, what is holding up interferon? And that's a big problem. But I think the first question is figure out your diagnosis and avoid cancer chemotherapy. Because again, you're not hitting the stem cell, but you can create acute leukemia. So I think those problems have to be solved.